So welcome. My name is Ellen Donald. I'm a member of the board of directors for the FSBPT, and I'll be hosting today's session. Before we get started, I just wanted to point out this QR code or using slido.com. There's going to be opportunities during this session to participate. So we would like you to join us that way. So if you want to pull that up on your phones. I just wanted to highlight that there in the next few weeks, we have more webinars coming up. We've got a regulatory hour coming up next week, talking about statutes, regulations, and policies. The following week, we are going to have a session that's really focused on boundary violations. So it's called Exploring the Challenges of Regulating a Hands-On Profession in a Hands-Off Era. And in August 5th, we're going to have a webinar regarding bias in the mirror. So we hope you join us for those. I want to go ahead and introduce today's session. Let me just see if one other thing I wanted to say is we want your participation. We really want your participation. There's some really interesting information being shared today. So we want you to use, even though we're using Slido for the interactive and the questioning and such, we would like you to use the chat within Zoom if you have any questions. So please post your questions on that you have as they come, and then I'll be reading them at the end of the session. So today's topic is imaging referral by physical therapists. And our three presenters today, the first is Chuck Hazle. He's the president of the Imaging Special Interest Group for the Academy of Orthopedic Physical Therapy. Daniel Markels is the APTA manager of state affairs. And Jeanne DeKrey is the president of the North Dakota Board of Physical Therapy. So I welcome everyone and thank our presenters for sharing their wisdom with us today.
All right, thank you, Ellen. So please, again, join in this poll. The Federation and the participants would really like to know who you are in terms of your role and interest in this topic. And so we see this being active real time. We see PTs probably as clinicians. We've got a robust number of educators and board members, including, and we also have a few others. Among the others, I believe there is a text window in which you can list what other is. So please feel free to share that. All right, so this is clearly a topic that has multiple angles of consideration, many dimensions to think about, and we would like to know who you are in terms of your interest. Okay. All right. All right, PTs by far leading educators, a robust numbers of educators. Again, that's heartening to see, and regulatory board numbers. Okay. All right, great. Thank you for participating, and I believe this will remain available. So let's go ahead and move on now. And I'm going to first cover really how we got to this point and to where are we progressing at this stage. Indeed, some might even start considering, is this actually emerging practice or are we past that? Because imaging referral by physical therapists is actually successfully established in many settings. But there is indeed growing interest in general practice here in the United States, especially in the musculoskeletal realm. All right, next slide, please. So if we look across the world, we see that physiotherapist referring is actually an established model of practice internationally. In Europe, in some of the provinces in Canada, and certainly in Australia, which may have the practice model that perhaps we would most like to emulate in being first contact providers, which there in Australia, of course, if you wake up with what you believe is a musculoskeletal problem, you can go straight to your physio and not even think about seeing your primary care physician. And physiotherapists in Australia have the capability of referring for imaging if they feel that is necessary. Next slide. Here domestically, we have increasing usage. again, it's been very well established. We have almost 5 decades of successful usage in the U.S. military. And again, this is with PTs in a primary care role. This was first documented by James and Stewart in 1975. And when they compared practice patterns of physical therapists compared to MDs and outcomes, what they found was, in fact, that physical therapists referred for imaging half as often as did the physician, and there was no apparent compromise in quality of care nor in patient satisfaction. Other federal institutions also have imaging referral privileges, and now we see growing use in civilian settings. University of Wisconsin Hospital and Clinics started referring for imaging around 2006. Now, they've had a bit of a tortuous course because they lost privileges and then got them back legislatively, but that's some of the things that Daniel will address. Georgetown University Hospital in primary care role has had imaging referral privileges for physical therapists since 2012, largely due to the work of Aaron Kyle, whose name we will mention further in this presentation. Colorado's Practice Act is written rather liberally and has been interpreted to allow for physical therapists to refer for imaging. And I know of some practitioners in Colorado who have been referring for imaging, including advanced imaging, for many years. And what we see happening now across the country are evolving circumstances in many individual states. Next slide. We also have more definitive work, such as this. The Veterans Health Administration published this directive in May last year, in which they specifically said that referring for diagnostic imaging is clearly a part of physical therapist practice. Next slide, please. If we look at the national circumstance, we can see Utah, recently North Dakota, and Wisconsin all have passed specific legislation. Other states have had favorable interpretation of their Practice Act and associated language that suggests that imaging referral is indeed within the scope of practice in those states. Daniel will go into much more detail on this in his section. Next slide. We can also look at what the APTA membership believes. In June 2016, at the House of Delegates, RC 1216 was passed with a 93% favorable vote, and that effectively charged APTA to pursue practice authority for imaging referral by a physical therapist. It charged APTA to address the processes and barriers, and in response to that, APTA has sought to analyze state practice acts and associated statutes and regulatory language. Next. And to briefly step back and look at the bigger picture here, of course, what we want to keep in mind again is this is about physical therapists having imaging referral privileges as a logical extension of our role as primary care clinicians. This is about making more informed, better decisions, that the examination or evaluation can include all the available data, and that the history and clinical examination can be supplemented by imaging data when that is appropriate. Again, all to allow better decisions, better patient management strategies, and ultimately that saves time and money. Next slide. Of course, this is consistent with the triage model of decision-making that we have come to accept over a period of many years. That this patient is not appropriate for physical therapy, this individual needs to see another provider of some type, or the patient's problem is fully within my scope of practice, I can manage this, or a combination of those in which the physical therapist makes the assessment of I can treat the patient in this way, but the individual may need to see another provider for additional care. And the concept of referring for imaging can fit very easily within this framework. Next slide. And just to clarify what the role of the physical therapist is, because this is something that comes up periodically in our interactions with physicians and specifically with radiologists. This is really about us understanding and acting and understanding how imaging integrates with our medical screening as primary contact clinicians, and also in our daily decision-making processes to enhance our clinical reasoning toward better patient management decisions, but not to presume to be radiologists. Next. And of course, if we look in the peer-reviewed literature, we have an increasing presence of imaging-related content in our literature. These two articles were published just this year in Physical Therapy Journal. And if you're not familiar with those, I would encourage you to take a look at those two. Next. What about education? Well, many curricula have incorporated imaging-related content for many years, but CAPTE made it a requirement on January 1, 2016, in which diagnostic imaging content was listed among the standards and required elements for accreditation. Next slide. This is a key piece that I always include in a discussion like this. Now, of course, the foremost guidance on imaging is the American College of Radiology appropriateness criteria. And if we go through the musculoskeletal and the neurological components of the ACR appropriateness criteria, this is what we would find. These are the individual items upon which decision-making toward imaging and the type of imaging is based upon. Age, whether trauma has occurred, the mechanism of injury, if there's been prior surgery, individual risk factors for the patient, the appearance, the physical appearance, pain provocation or physical function test, other imaging results, weight-bearing ability, and tenderness to palpation. My argument is always these are all incorporated into basic physical therapy education, and are these not what physical therapists base decisions on an everyday basis anyway? Next slide. We also have outcome data. We can look at this study. Springer et al. Was published over 20 years ago. In this study, they looked at physical therapists and orthopedic surgeons using guidelines such as the Ottawa ankle and foot rules, and they found that PTs and orthopedic surgeons were equivalent in their competencies to use these guidelines. Next slide. We also have outcome data in this direct access setting by Kroll et al. In 2016 and Aaron Kyle in 2019 from his work at Georgetown University Hospital. In both of these circumstances, what we see is that physical therapists made appropriate decisions consistent with the ACR criteria, and that their patient management decisions were appropriate in overall care of the individuals. Next slide. And the last item I would like to close with here is work done by a couple of third-year physical therapist students. They surveyed during 2020 the state associations around the country, and what they found and presented at CSM earlier this year was that 17 state associations actually indicated moderate to high levels of interest in pursuing imaging referral privileges as part of their overall strategic plans within the next 5 years. And with that, I will transition to Daniel, who will expand on some of the topics that I have introduced. Daniel?
Thanks, Chuck. Again, my name is Daniel Markels. I work here in Alexandria, Virginia, in APTA's State Affairs Department. What I'm going to be talking about are state laws and regulations related to physical therapy referrals for imaging. And with that, if we can go to the next slide. Now, authority for physical therapists to refer for imaging. Now, it's important to understand that the statutory authority to order image studies, what we're looking at, is generally separate from the authority to interpret those findings, really what a radiologist or an MD would do. So in terms of the authority, we need to look and see if it's granted overtly through explicit statutes or regulatory authority, or denied by statute or by a regulatory authority. Now, in most states, what you'll find is that the applicable laws and regulations are really silent on whether physical therapists can order imaging studies for their patients. Next slide, please. Now, these are the 7 states that we've identified that expressly allow for physical therapy imaging referrals, and they do this through a variety of different ways, which we'll see as we examine each of them. Next slide, please. So as I said, keying off what I just said is use a variety of approaches, and let me just identify those. First, we have state statutes, likely could be in a Physical Therapy Practice Act or a medical or radiology statute. It could also be, if it's a rule or regulation issued by a board, or a board may issue an opinion. Next slide, please. The ability of PTs to order imaging studies in the state of Utah can be found in their Radiologic Licensing Act. And under that act, radiological technologists, assistants, and technicians are allowed to accept orders from physical therapists for both X-rays and MRIs. Next slide. In Colorado, PTs can order imaging studies, including MRIs, as directed by a Colorado Physical Therapy Licensing Board policy, as you can see, that was issued on March 21st, 2014. Next slide. Wisconsin amended their Physical Therapy Practice Act to allow PTs to order X-rays. As you can see, this was the language that was added that basically says physical therapy does not include any of the following: using roentgen rays for radium for any purpose, except that physical therapy includes X-rays to be performed by qualified persons. So they passed that statute, and then following that, next slide, please. Following that was more detailed regulations that were adopted. Among other things, those regulations require PTs to complete a formal X-ray ordering training program with demonstrated physician involvement. The regulation also requires PTs to communicate and coordinate with the patient's primary care physician or appropriate healthcare provider when ordering X-rays, with some exceptions. Next slide. North Dakota just this year enacted a Practice Act revision that allows PTs to order imaging. And as I think was mentioned in the beginning, Jeanne DeKrey from the North Dakota Board is going to go through their experience in more detail following my remarks. Next slide. And this is basically the language, the last slide in this one that they added. Okay, next slide, please. 2010, the District Columbia Board of Physical Therapy ruled that PTs can order diagnostic imaging studies. So that just basically was not legislation, came from the board. As did, next slide, please. As Maryland, similarly, the Board of Physical Therapist Examiners in Maryland also took the position that PTs can order imaging studies, including specifying 2 years after they initially allowed that, after the initial direction, that this includes X-rays, MRIs, and CT CAT scans. So their initial policy was promulgated in 2012, and then 2014, they got more specific and allowed specifically for X-rays, MRIs, and CAT scans. As you'll notice, some of the laws allow just for X-rays, others allow for other types of imaging studies, such as MRIs or CT scans. Next slide, please. In New Jersey, in 2016, the Board of Physical Therapy Examiners approved a motion at a board meeting allowing PTs to refer patients for diagnostic testing, including imaging studies. Next slide. Rhode Island legislature actually just last week, well, the legislature passed and then the governor signed last week Senate Bill 232, which allows physical therapists to order x-rays. So not MRIs or CT scans, but x-rays. Next slide. Yeah. Now, this legislation includes a requirement that a PT who orders imaging must, within 7 days of receipt of the results, report the images, that they report those to the patient's primary care physician if the patient has a primary care physician. It also requires managed health plans to provide a utilization report back to the legislature annually starting in 2022. And lastly, the legislation sunsets after 2023 unless it is reauthorized. All right, next slide, please. Now, if you're a state that is not allowing imaging or it's silent on imaging, the first thing you need to do is when evaluating, what approach you should use, meaning a statute change, changing a practice act or other legislation or other parts of the code, a regulation, a rule change, or a legal opinion, determining which is the best course of action. It's recommended that you should first look at the statutes and regulations and board opinions to see if there are any prohibitions on PT imaging referrals. Next slide. Now, as most states have no explicit prohibitions on PT imaging referral, you can first consider having the board's legal counsel or attorney general's office issue an opinion on such, if that's appropriate. Or the boards may choose to issue a rule or regulation or policy. Boards can choose a general policy, as Colorado did, or a more detailed rule, as Wisconsin did, that specifies such things as training requirements. Next slide, please. Now, in states where there are explicit prohibitions on imaging referral, if those are in statute, new legislation, or if they're in regulation, new regulation will likely be needed depending on whether, like I said, those prohibitions are in law or in regulation. So you'll find that there are prohibitions out there, but in the vast number of cases, at least, what the research we've done is that most states are often silent on the issue. Okay, next slide, please. As Chuck indicated, I think from their survey, they mentioned 17 states that were interested in looking at this issue. APTA chapters, from what I'm hearing, talking to them, are increasingly interested in potentially pursuing efforts to explicitly allow imaging in their states, whether it be needed by statute, rule, policy. We recently had this success in North Dakota that you'll hear about, as well as preceding that was in Wisconsin. So to folks that are on the call today that are coming from licensure boards, I would say to expect other APTA chapters to reach out to you as imaging becomes more within the scope of practice of physical therapy. Next slide, please. Okay, we're going to do a poll question as we did earlier, and this one is going to be, the question is, are discussions about imaging referrals happening in your jurisdiction or chapter? Wow. Okay, so went from 100 to, let's see where it settles at. Okay, 83% yes, 12%, 14% no, 10% I'm not sure. So that's great. So it sounds like there's definitely a lot of interest. So what I suggest to do, if you are interested, is to, from my perspective, I work with our APTA state chapters in each of the states, is to reach out to them, to reach out to their executive director, president, or any contact that you have in their chapter leadership, and they can look into having a chapter, move forward with advocating for such. All right. Now I will turn it over to Jeanne DeKrey from North Dakota.
Sorry about that. Still working to figure out the technology, apologies. So interesting to listen to the other presenters, but yeah, we are probably the newest birth along the way. So this is a very timely thing, and just excited to be able to tell you our story and kind of the interaction. Next slide, please. And I think, probably one of the things that, having been involved with the board and with the Federation, Practice Acts definitely are living documents. We need to keep up with the environment and the changes, what's supported by our education, what's supported by practice. And I would say that one of the things that I feel almost a little and I'm really pleased to tell you that our chapter president, Cindy Flom-Melland, is actually on this call, and I give them all the credit for being the carriers of this. But our relationship between our board and between the APTA North Dakota chapter has just been very productive. We don't agree all the time. There's some definitely overlapping scopes and interests. But we have designated liaisons to attend each other's meetings. We're really dedicated to a really good, open, honest communication. So there's no surprises, which really helps a lot. But I think, as Daniel said, at the APTA and the state chapters are generally in a little better position to probably be the drivers, and just having that relationship in order to be able to work constructively has been really helpful for all of us. I also like to kind of shout out our board attorney is also on this call, so I need to stay honest with everybody. Next slide, please. I think we have another word cloud here. So just using a couple of words, can you let us know how the communication is working between your state chapter and regulatory board, if you know that, from excellent to non-existent to we're working on it, whatever that might be, please. Yeah, so it looks like in general, it looks really pretty positive, although there's a few in here that are probably frustrated from either direction. And, probably some of that depends a little bit on both your board structure. And I think there's sometimes in North Dakota, we feel like, oh, we're a bit behind because we're pretty small, but I think in some ways everybody knows everybody. Oh, anemic, I like that word. Actually, I like it as a word that could hopefully be improved. So excellent. Well, thanks. And I guess I would just encourage, for those of you who are frustrated, try to look at what you might be able to do to help to make that a little bit more collaborative. But the fact that good and excellent are the two words that show up the strongest is really encouraging. So kind of a real quick about our timeline. We kind of got nudged towards this. Back in May of 2016, we had a PT who sent a question to the board and was on our meeting agenda, and just really looking to see how we felt about ordering imaging studies and also labs, and kind of goes back to what Daniel said, it's pretty silent. Our board structure has changed a bit since that time. We actually had 2 physicians on our board who were physical therapists prior to being docs. And we kind of at that time said, we really are a little ambivalent about it, but that we really thought, getting the person to the right the PT wasn't the portal of entry at that point. And so we kind of said, no, at this point, we're not supportive of that. We didn't have a policy. We just responded back directly to the PT that was questioning. Next slide, please. And then 2 years later, and I'm not even sure, I think some of this was triggered by some of the background conversation, but I think probably, as Chuck and Daniel have both said, the ability to own and operate equipment versus the ability to access and refer probably are way different questions, as well as the payer questions I was starting to see in the chats a little bit. But basically, our North Dakota Department of Health doesn't allow a PT clinic at this time probably to be able to own X-ray technology. And, that might be something that's down the line, but they're current. So there was still some background conversations going on and leading to the next slide, please. And I would like to say one of our licensees, but this was actually our same very proactive physical therapist. He just got directly in touch with his legislative representative and drafted a bill to be introduced to allow imaging and change the Practice Act. The cautionary part here is neither APTA North Dakota, our chapter, or our board were aware, and the legislator and the therapists were willing to withdraw this kind of after the discussion that there really needs to be some background work done to kind of all of the interested parties, kind of building your case. Felt like something coming out without widespread support was probably likely not to be successful. But at that point, APTA North Dakota had begun investigation, kind of all of their footwork. And at their winter board of directors meeting in January, they invited our board and the past and current presidents from APTA Wisconsin. And I think because of what had happened with Wisconsin of having privileges, kind of having them taken away, having to go back again, was sort of laying the groundwork to what that path might look like in North Dakota. Next slide, please. So we come back around kind of the same question 3 years later, and the board discussed the role in promoting physical therapists' ability to order imaging studies, and really concluded that we were not opposed to it anyway, but that it was probably going to be more of the responsibility of the state chapter to be able to bring that forward. And so the statement that we had on record was a little bit bland, just that we're not going to oppose any legislative efforts enabling physical therapists to order imaging studies. And you'll see that show up in a letter submitted as testimony here in a bit. And the next slide, please. So it come to later in the year, September 2020, our state chapter kind of let the board know that it had intentions to introduce 2 bills in our upcoming legislative session. And the first one was really just an expansion. We've had pretty unfettered direct access for a long time, other than with our workforce safety and insurance, and we're a mono payer here. And so they, and actually kind of an encouragement, they allowed us to be able to add PT to the list of healthcare providers. And the other bill allowing physical therapists to order medical imaging. Next slide, please. So then our board said, yep, here's kind of the history in the last couple of slides that have been discussed, and then also the statistics that Chuck has done such a nice job that what's the history been with physical therapists? What's the military history been along with this? And then the second half of the letter is on the next slide. Basically, our little statement, we won't oppose the legislation, in the last sentence, that our board supports a due pass for this bill. And I think it was also probably an encouragement for the legislators to contact us with any concerns. And I think the fact that we had amazing testimony brought forward by the chapter was really pretty strong, and amazing how well it passed through committees to the House, to the committee, to the Senate, and the governor. Actually, I guess when the governor signed it, and I'm kind of quoting what I've heard from our chapter representatives, he was sort of surprised that we weren't already able to do this. So he had no problems with the signature part, apparently. Next slide, please. And I think one of the things that I would encourage those of you who are looking at some of these changes is this is just really a great resource document, and being able to go back and again look at, what's the history, what's our education. I think, again, our biggest job is probably to stay out of the way and not create unreasonable barriers in terms of the regulatory process. And this is a pretty helpful document, I think, for the legislators, and just to help other people understand how things have changed over time as well. Next slide, please. So result, successful passage, and our effective date is August 1, which is a Sunday, kind of interesting, but about 2.5 weeks from now. And the original language was much broader. It really did encompass imaging without definitively saying x-rays only. But there were the State Medical Association and our North Dakota Medical and Imaging Radiation Board were the two that had the biggest concerns and narrowed the language down. And I think I wasn't involved in all of the preliminary things, but that it was an understanding that this was going to be probably a potential compromise situation. And I think for those of you who are more interested, I know that Daniel and Chuck are going to be working with our chapter president for another session on the professional side coming up in August. But my understanding is that it will be a collection of data over the next couple of years, and hopefully this is not the end point of all of this. So the board's next task, as you had seen from the language that Daniel had already had presented, that a physical therapist may order musculoskeletal imaging consisting of the plain film radiographs if the physical therapist holds a clinical doctorate degree in physical therapy. And if not, there needed to be completion of a board-approved formal medical imaging training program. Next slide, please. We didn't get as involved, I think, as Wisconsin did. I would say that we've been very fortunate to also have on our board faculty members who are able to, kind of assist us with, what do we have out there that's kind of comparable to what might be coming up in the doctoral programs. And again, just probably give another shout out to Aaron Kyle that he was here in April for our education, and that his course, and he put together, allowed us to record it and wrote up a test for an 80% passing competency. So that was kind of mechanism number one that's available. And I know our chapter is working on that right now. MedBridge has a cluster of 4 online courses that will be one of the other options. And then looking at the monographs from the Academy of Orthopedic Physical Therapy for clinical imaging. And number 4, imaging courses that might be available as part of an approved TDPT curriculum if those universities would allow a non-fully participating student to be part of that. And I think here we also realize there might be other things out there we haven't considered, and that we will certainly look at those as they come forward. But we kind of felt like we needed to, at the August 1 date coming up, we needed to put a couple of options out there sooner rather than later. And the timing is kind of interesting on all of this, that today is the day that these 4 options are going out to all of our PT licensees. So you guys are kind of seeing this at the same day that our PT licensees are. And, hopefully we did want there to be a little bit of a variety of things, but we were also very confident that we were getting the content covered that we felt was necessary. We also didn't want to make it more complicated than it needed to be. So this is where we are so far, and more to come, I guess. So that is all I have at this point, and turn it back over to Ellen.
Thank you. Thank you, all 3 of you, for a great presentation. It's a great background for, other states to be considering this, as well as the success that North Dakota has had. Congratulations. There has been some messages in the chat I wanted to highlight, which has gone away. There it is. Let me just scan it for a minute. There was a message from a participant that said in those, and anyone can answer these questions, in those states that allow PTs to order imaging, do insurance carriers cover the cost of imaging if the imaging is ordered by a PT rather than a physician?
I can answer that to some degree. In Aaron Kyle's publication, he specifically addressed that. And then actually, if we go back to our CSM presentation earlier this year, in which we had representatives from other states, in each of those situations, there were no denials as described by those individuals. There were no denials for the imaging to be reimbursed if the referral took place by a physical therapist. Now, of course, that's, Jeanne described Practice Acts as being living, breathing documents. I think what happens with reimbursement is also extremely very changeable. Now, we have looked at the imaging SIG has looked at that specifically in reference to ultrasound reimbursement, and that's a little bit of a different circumstance there. There have been some significant issues with ultrasound reimbursement, diagnostic ultrasound reimbursement across the country, and that varies tremendously based on your location, who the insurance carrier is, and believe it or not, the individual contract. So that's something the Imaging SIG has been working on, and we're trying to form a collaborative effort with APTA to inform these providers about physical therapist competence with diagnostic ultrasound as well. And the Imaging SIG has done some specific work in working with the American Institute for Ultrasound in Medicine and Intellios, which is the credentialing agency that offers the RMSK individual credential that is the same credential that physicians can earn too. So one of the key things we're looking at is to try to encourage more and more PTs to get the RMSK, because that puts you on an established level of competence commensurate with physicians. So it's much more difficult to say, no, we're not paying you because you're not capable of doing it. If you've demonstrated the same level of competence with diagnostic ultrasound, that's not an easy credential to get, but it certainly gives us more bargaining power from a reimbursement angle.
Great, thank you, Chuck. Does anyone have anything to add to that? I'll go in. Actually, you beautifully led into the next question. So Janice asked that, does any of this legislation routinely include ultrasound? Can they conduct a diagnostic ultrasound? So does anyone have any more to say about that?
Daniel, do you want to address that, or you want me to jump in?
Yeah, you can. Well, as you can see, of the states that I listed, at least the two most recent, North Dakota, that legislation was, as Jeanne mentioned, was specifically for X-rays, as is the Rhode Island legislation. In other cases, as you saw, they were more general and did not call out each specific technology. In other cases, they did call out those technologies, like I think it was Maryland, where they had it. I'll have to go back and look if that's the right one. Just one sec. Where they initially, in 2012,
might have been DC
Maryland, yeah. So basically, what happened in Maryland, August 2012, at their meeting, they basically said that PTs can refer for imaging, and then they came back with a more specific proposal or policy that's clarified that included X-ray, MRI, and CT scans. So I don't see that included ultrasound in that case. Chuck, do you want to add anything?
Well, if you look at imaging overall, most state practice acts are simply going to be silent on it. Places where it may be prohibited are often other areas. Now, of course, the state practice acts can contain language like what Daniel mentioned, where they specifically prohibit use of radiation, et cetera. But that's not what we're doing. We're referring patients. We're not flipping the switch. We're not exposing patients to radiation. So that's a completely different circumstance. As Jeanne described, it's a different frame of question here. So with imaging overall being silent in most circumstances, ultrasound, to my knowledge, is not mentioned anywhere. This is an area that does come up, and there is more gray surrounding this. I suspect it simply hasn't caught a great deal of attention because the number of physical therapists doing ultrasound on a routine basis is not enough that it has caught a great deal of attention yet. I'm not aware of it being specifically prohibited, but I know that there is an ever-growing interest in physical therapists doing diagnostic ultrasound. I think another key point to keep in mind here is that the diagnostic ultrasound is done to supplement the clinical exam. It's not done as an imaging study to stand alone. And I think that is a context that is really important to keep in mind here. It's done as to augment the clinical examination, to give more information. So a physical therapist is not making a diagnosis just flipping up an image the same way that a radiologist looks at an MRI and then runs off 3 pages of narration.
That's good clarification then. So we've got actually a lot of activity on the message board. There was a quick question that was from Slido. It said, you mentioned that Virginia's approval for PTs to make referral for imaging. Is there anything in the works within CMS?
I think that's the VA, the Veterans Administration.
VA, you're right. Mm-hmm.
Yeah, CMS is going to be the holy grail. CMS currently has a list of providers who can refer for imaging, and physical therapists are not on that list. That's obviously an objective. We've all had our battles with CMS, so I'm not sure if the environment currently is good for us to go for that or not. So I don't know. That's more of a national question. Daniel and the folks at APTA are better qualified to answer that than I am.
Yeah, and I'd have to look into that. I really focus on the state level, and I'd have to talk to my federal counterparts to see if there is any movement there.
Yeah, that was a very good question. Stevens asked the question, given that imaging adds to the total cost of care for our patients, are there any studies or indications that the ordering of imaging by a physical therapist decreases the number of visits or increases efficiency or improves patient outcomes compared to physical therapy care without PT imaging?
Before I was just going to mention, if you notice in that Rhode Island bill, they're going to require utilization. And Jeanne might even talk about that as well, because I know that probably often does come up as legislatures and regulatory bodies. The fear is that it's going to be overused and be very costly and not always necessary. But Chuck, you want to go into more the background of that?
Right. Demonstrating the actual reduction in cost of care per patient is a little more challenging to do. One of the things that we see, though, is anytime there has been a comparison at the rate of utilization of imaging referral by physical therapists to what physicians do, not sometimes, but every time that comparison has been made, physical therapists refer for imaging far less than physicians. In my era of clinical practice, I graduated from PT school in 1990. And in that time frame, I saw very quickly, and this is actually well documented in the literature in medical education, that medical schools started de-emphasizing teaching the clinical examination. And so imaging became the default to look for more information. And that's how imaging, that was one of the key pieces in imaging overutilization. I'm not slamming on physicians here, because your primary care physician has to treat every possible circumstance that walks in the door, but it's really a byproduct of medical education in response to advanced imaging with CT and MRI being developed in the 80s. The thought was, oh, this shows everything. we don't have to do a clinical examination now. And now we're circling back around to realize, well, we still need to do the clinical exam. And that's why physical therapists time after time show very favorably, because it's appropriate use of the history and the clinical examination that informs the imaging decision-making. It's not a substitute for those.
Yeah, one real quick comment about our legislative, and again, I give all the credit to our chapter, but our one person who got up and testified negatively in a committee was our director of human services, who that was his concern. We were concerned. We think this is going to raise costs. Fortunately, he came up right after Brigadier General Bob Schulte, who is a faculty PT, and he was in charge of kind of our coordination for COVID in the state, and very well respected. And Bob had effectively kind of answered all those questions, and with a lot of the information, the background studies that Chuck's talking about in the military. And I know that those testimony things are on our legislative website, and if anybody's interested in them, let me know. I can get the links to, the Federation, or contact me directly, because it's public record, but it was just extremely well done and kind of addressed it very effectively.
The two articles I mentioned by Aaron Kyle and Michael Kroll, I would encourage those that are interested in that kind of information, go look at those manuscripts. I think you'll find some good information therein.
Interestingly, your state, Jeanne, North Dakota, Rhode Island, just this past week in approving it, they just approved it for X-ray and not for MRI. I understand MRI is a much more expensive test. They said basically, as I understand it from your angle, that they felt that MRI wasn't appropriate, that you didn't have the proper training. I don't completely understand that. I would think that it probably had a lot to do with cost.
And I think a lot of it really, as Chuck had said too, with CMS, you have to really look at what is the political climate, that some of this is like making sausage. You kind of have to deal with what your factors are, what your environment is, and realize you may not get everything you want right away, even if it's really well justified. And I do think that our chapter is looking at collecting the data and hoping to come back and expand this in the future. And again, a plug for the upcoming webinar through APTA in August, probably for more on that.
We have actually several more questions. One is in the states that were successful adding this to their Practice Act, was there any pushback from the medical society or the chiropractors?
Oddly enough, the chiropractors were very silent on this one. And there were a few docs, the medical association a little bit formally, but some of the sidebar conversations that I know I had with our orthodox said, you guys have way more background for this than most of our mid-levels do, who have this privilege right up front, talking about PAs and NPs, depending on their practice setting. And again, that was why it got whittled down from the broad imaging to the x-rays for this first go around, with the concerns there and from the radiology providers, I guess. The other interesting thing was, I think the original language also said that it would need to be interpreted by a radiologist. And the doc said, whoa, that's way too limited. How about doctors who have experience with radiology? So they wanted to narrow us and broaden them at the same time. But I think it made them think about it anyway. And again, Cindy may have probably a lot more detail on that than I do.
And Jeanne, I'm going to ask the next question of you. Or Chuck, did you have something to say?
Well, I think that if you look around at some of the other states, there have been some concerns from medical societies, and if you look at all this realistically, a lot of it is first impressions based on a lack of information. And if there is adequate information, and if the state chapter does its work and conveys all the facts, most of those arguments can be crushed.
Like many of the things we've dealt with our practice acts. Jeannie, how did North Dakota decide on the appropriate training for physical for therapists, not with the DPT? And I think it was a clinical doctorate you only referred to. And was this a board decision or a state chapter recommendation?
You know, we asked for input from our chapter and also from our board members who are faculty. And one of our board members actually teaches radiology in a transitional program. And so I was kind of like, you know, what is the content? How does this compare? So we looked at, you know, what things were brought forward, kind of tried to at least offer a few options. So ultimately it was a board decision because it was legislatively mandated, but we sought input as to what the other interested parties thought would be appropriate, but for us to decide if it met the threshold or not.
One thing to keep in mind with that too, it's just a question that every jurisdiction has to ask, and a state board would have to ask as well, is do you want to start dividing a license?
Mm-hmm.
Do you want to take a license and say some of you can do this and some of you can't do that? That can lead to a somewhat dicey situation. And it's, I'm not taking a side here, but it's a question that you've got to ask and be prepared for the consequences if you do something like that.
Agree. And we had this same kind of issue a couple of sessions ago when we added manual therapy and manipulation into our practice act and the chiropractors. And it basically was saying, you know, if you didn't have this, if you're not part of if you don't have a DPT, tell us what your qualifications are for that. So again, it was offering an opportunity, a bridge to do that. And then also just reminding every PT, they need to know their boundaries, what their expertise is, where they need to say no and where they need to refer on. But yeah, we don't want to make it any more complicated. We were legislatively mandated to kind of do this and tried to make it as straightforward as we could.
One time for one more question. Joyce asks, as a member of a work group to modernize our state practice act, there's been a bias to just let the issue of referral for imaging remain silent. This seems to be a head in the sand approach. Can you discuss the relative merits of being proactive versus remaining silent?
I will mention one, and then I will stay silent and let the other people go forward on that. If you stay silent on it and wait for somebody to tell you no, I think it does increase the risk regarding reimbursement. Whereas if you have explicit language and you have specific legislation, those payors have a much more difficult time not paying, whereas they can mount an argument to not pay because they can say, where does your practice act say that you can refer for imaging? Tell me how this is. So there's something that you have to look at there. But some people actually do prefer the approach in that nobody's telling us that we can't, so we can. But there are risks that come with that. And I will leave it alone at that point.
Yeah, I don't know if I have a specific recommendation one way or the other. I mean, practice acts have all sorts of things that you can and cannot do, but there's a lot of things that are, you know, it's an evolving profession. Things are always changing, and practice acts are designed to be flexible. And then that's why we were saying, you know, before you go do this, if you decide to do this explicitly and want it explicit, oftentimes better to go to a board and to get a ruling or an opinion before going to put it in statute, which is a much more expensive, time-consuming way to go. So definitely, if you're going to do it, I would definitely look if there's not a prohibition. I mean, as I understand it for North Dakota, and correct me if I'm wrong, Jeannie, I think there was something that prevented you from doing it in statute, and that's why you needed to go change your statute. I might be wrong on that, but I thought that was the
Yeah,
case.
I don't think there was any exact prohibition. We just knew that there was resistance out in the community. And that's, I think, when the chapter got together for their strategic planning and kind of included Wisconsin in on talking about the pros and cons. And probably part of it was our earlier approach of saying, no, we don't think so, prior to kind of saying, you know what, we're compelled by the evidence to say there is no reason for us to oppose this. With dry needling, we were just able to put out a policy there. We didn't need to go through all of the same hoops with that. And I think was maybe the more perception of the resistance, whether it was the payers or the other providers, that this might be the best way to go.
I think that with all these changes that we try to do to expand or clarify our practice acts, the collaboration between the association, state associations, and the boards is going to be really critical. And it's different in every state. So I want to thank everyone. We're out of time. Unfortunately, there was actually a few more questions. Hopefully there'll be more conversation on this. And Chuck, was there or Jeanne, you mentioned a upcoming webinar from the APTA. Does anyone want to plug that real quick and we'll sign off?
I'll throw that back to Daniel. I think I know it was for state chapter leaders for sure, but I don't know if it's open to other interested parties as well. And I had at that point said, you know what, I'd really rather have our chapter president be the spokesperson because she knows the details, and I'm just going to be there as kind of a resource support person.
Yeah, I'll just I'm basically putting that together we basically have regular Zoom calls with our state chapter presidents, executive directors, legislative chairs, and state lobbyists to talk about all sorts of things. And we're doing a number of webinars over the summer and fall on a variety of topics. And I thought, since we were doing this for FSBPT and my colleagues were gracious enough to do an encore performance, this is basically just another way to get the message out to and this valuable information, the history, North Dakota's experience, what's going on nationally, to that different audience. And maybe someone on this call is part of that audience too. But it's just an effort to get it out to that audience. And Cindy Flom Mellon, who is the chapter president, is gonna talk about North Dakota,
right,
to her fellow chapter presidents and the partnership that they had with Jeanne and their board in passing that legislation.
Ellen, and if I may plug briefly an upcoming webinar by the Imaging SIG. This will be in October. One of the things that we're going to do is with Rhode Island is right there on the cusp. They're likely to be the fourth state to successfully complete this. And so we're going to have the state chapter presidents, along with potentially their legislative chairs, for each one of those states to describe their story of how they accomplished this. So that's going to be a webinar sponsored by the Imaging SIG through the Academy of Orthopedic Physical Therapy. And I believe the date of that is October the 12th. We'll have more information about that coming out in the not so distant future.
Very good. Thank you, Chuck. So I want to really say thank you to Chuck and Daniel and Jeanne for sharing their experiences and their wisdom. And we'll be looking out for more information on this topic.
My pleasure. Thanks
for your time.
Thank you all.
Thank you, everyone. Thank you, FSBT,
Thanks.
for putting this together.